Hello dear students and the members of the fraternity of Physiology and Medicine. In the next few videos, I am going to discuss the environmental physiology, how body responds to the environmental stress in the form of low barometric pressure or high barometric pressure or extremes of temperature, exposure to cold or exposure to heat, and the acceleration forces or gravitational forces, and so on and so forth. So, this video is about the problems of low barometric pressure and the resultant hypoxia. Now, before we start this discussion, let me just define two things. What is acclimatization? Now, acclimatization is the short-term adaptation of the body or physiological systems adopt to the physiological stress or environmental stress in a short-term manner. So, that would be loosely referred to as the acclimatization, whereas adaptation is the term used when there are long-term changes. In fact, there are genetic changes that happen in response to the environmental stress faced by the body and its physiological functions. So, acclimatization and adaptation, these two terms should be known at the outset. Now, let's start with the exposure to low barometric pressure. Now, basically, this is going to pose the challenge of hypoxia. Let's first understand who will get exposed to such low barometric pressures. Either it could be sudden. For instance, there is a sudden loss of cabin pressure in the aircrafts. So, a low barometric pressure. So, it could be sudden, or it could be short term, as seen in mountaineers, those who are climbing and ascending into the mountains. So, on a short term basis, they are going to face this low barometric pressure and hypoxic situation. Or it could be permanent, in the sense there are habitats at the high altitudes, and they would be permanently facing this stress of low barometric pressure and the resultant hypoxia. So, three ways in which a person is likely to get exposed to the low barometric pressures. Now, basically, I am going to discuss this in three parts. First is, what is the problem with the low barometric pressure? I mean, we are residing at sea level and there is a certain barometric pressure, 760 mm of Hg. Now, when we ascend into the mountains, or the mountaineers, when they go into the mountains, there is going to be a low barometric pressure. What's the problem with that? So, first part will be related to that. Then second part will be how the body responds immediately to that low barometric pressure. And the third part will be the acclimatization to the hypoxic environment. So, let's start with the first part. What is the problem with low barometric pressure? Let's take the case of mountaineers who are ascending into the mountains. What's the real problem? Now, as I mentioned, it's going to be a problem of hypoxia. Why? There is no less fraction of oxygen in the atmospheric air at the heights. The fraction of oxygen is going to remain the same, let's say around 20%. However, as one goes into the heights, the barometric pressure surrounding the body is going to be less and less and less. Let me just explain this. At sea level, the pressure is 760 mm of Hg. Now, mainly it is nitrogen and oxygen. I'm for the time being I'm ignoring these smaller fractions. So roughly nitrogen 79 point something and oxygen roughly about 20%. So 20% is the fraction of oxygen in this atmospheric air at sea level. And therefore, the partial pressure of oxygen at sea level is going to be roughly about 159 mm of Hg. And we are inspiring this air with this much oxygen at sea level. As we inspire this air, and right now I'm talking about the sea level, as we inspire this air in the dead space, in the respiratory passage, the partial pressure of oxygen is going to decrease because of the humidification of air. When it reaches the alveolar air, partial pressure of oxygen will decrease further. That's 104 mm of Hg. Now, this oxygen is going to diffuse into the pulmonary blood. The blood is going to be oxygenated. So, when mixed venous blood comes into the pulmonary artery and it's entering the pulmonary capillaries, the PO2 will be roughly about 45 mm of Hg. And therefore, you can see that there is a certain pressure gradient, and therefore oxygen will diffuse much faster from the alveolus into the pulmonary blood and it will equilibrate. So, this is what is made available to our body. In fact, partial pressure of oxygen in the arterial blood is slightly less. It's about 95 mm of Hg till it reaches the tissues. So, this is what happens at the sea level. Now, imagine that a person ascends into the mountains. The barometric pressure itself is going to be decreasing as one ascends higher and higher. So, oxygen fraction would be 20% of that barometric pressure. I mean, if the pressure of the atmosphere into the mountains is 600 mm of Hg, then oxygen will be 20% of 600 mm of Hg. And correspondingly, less pressure of oxygen in the dead space, less pressure of oxygen in the alveolar air, and therefore what's going to happen is the gradient for oxygen diffusion or a gradient for partial pressure of oxygen from alveolus into the pulmonary capillary blood, that gradient is going to narrow. Therefore, less oxygen will diffuse because, as I mentioned, barometric pressure less, therefore PO2 in that air is also less, 20% of the total pressure, and therefore PO2 in the alveolar air also is going to be correspondingly less. That means less oxygen will diffuse because the gradient for diffusion of oxygen is going to narrow from alveolus to the pulmonary capillary blood. So, oxygen may not get even chance to completely equilibrate from alveolus to the pulmonary capillary blood, and therefore PO2 in the arterial blood is going to decrease and there would be a resultant hypoxic situation. So, that's the reason. There is no change in the composition of air, but because the total pressure itself is less, therefore partial pressure of oxygen in that air is going to be less. Therefore, alveolar PO2 will be correspondingly lower and the body will face hypoxia. So, that's the first point which I wanted to make. Now, for every 1000 feet ascent into the mountains, the barometric pressure decreases by about 26 mm of Hg. So, At sea level, it's 760 mm of Hg. As one ascends higher and higher, for every 1000 feet going up at the heights, the barometric pressure is going to decrease by about 26 mm of Hg approximately. Now that's the first part. Why is there the hypoxic situation, which is what I explained just now. Now let's see the second part, how body reacts to it immediately, and then how the body reacts to this hypoxia. Let me just add, this type of hypoxia, of course, is called as hypoxic hypoxia. So the second part is how the body will react immediately to this type of hypoxia. Let me at the outset say that the hypoxia is sensed by the peripheral chemoreceptors. You know, we have peripheral chemoreceptors in the carotid bodies and the aortic bodies. So we have carotid body which contains the glomus cells, which are chemoreceptors. These are peripheral chemoreceptors. And in the arch of aorta, we have several aortic bodies. So what do they sense? They would sense this hypoxia. Whereas there is also the central chemoreceptor in the medulla. We have the central chemoreceptor. Now this central chemoreceptor is going to respond to the changes in the arterial CO2. You must remember this fact at the outset, that the central chemoreceptor is it's going to respond to the changes in the arterial CO2. Now remember, arterial CO2 will cross the blood-brain barrier. It will enter the brain and enter the CSF. There it will combine with water, CO2 combining with water to form H2CO3, and that splits into H plus and HCO3 minus. And these H plus, then the hydrogen ions are then going to stimulate the central chemosensitive area, and they will stimulate the ventilation. So increased CO2 and H plus will stimulate the ventilation via central chemoreceptor, and decrease CO2 and H plus, decrease arterial CO2, and therefore decrease local H plus is going to depress the ventilation by acting via the central chemoreceptor. Please keep this fact in mind. And now let's try to understand how the body reacts. Now, hypoxia is going to increase the ventilation, and therefore the alveolar ventilation is going to increase because it's going to be sensed by the peripheral chemoreceptors, as I mentioned just now. And it will be just noticeable, the increase in the ventilation is just noticeable at about 8,000 feet. So there is a fall in the arterial saturation from 97% to 93% or so, and also there is a decrease in the PO2. That will be sensed by the peripheral chemoreceptors and ventilation stimulated. The other change is hypoxia causes pulmonary vasoconstriction. So blood flow to the alveoli is going to decrease. Remember, hypoxia elsewhere in the body causes vasodilation, but in the lungs, the hypoxia causes it causes constriction of the pulmonary vessels. Now, combining these two factors, the person is going to start feeling dyspneic, breathless. There is increase in the ventilation, but there is no blood flow, proper blood flow to the alveoli because pulmonary vasoconstriction is happening, and the person will slightly start feeling breathless. At the height of 10 to 14,000 feet, I am taking just one unit, let's stick to feet, 10 to 14,000 feet, the alveolar PO2 drops to about 60 mm of Hg. Now remember, at the sea level, it was in the range of 100 mm of Hg. But as you go higher up, it's going to drop to about 60 mm of Hg. And hypoxia-induced hyperventilation is now going to significantly increase. Ventilation will be almost doubled. And at the height of 16,000 to 20,000 feet, chemoreceptor discharge, the peripheral chemoreceptors would discharge maximally, and pulmonary ventilation is going to be maximum. So, this is what happens as the person ascends into the mountains and faces the hypoxic situation. Now, coming to the more important physiological aspect of this, hyperventilation occurs in two phases. This is the most important physiological parameter that you should understand or concept. First immediate effect is that the hypoxia will increase the ventilation by acting on the peripheral chemoreceptors, carotid bodies, aortic bodies. They will sense the hypoxia, they will send the signals to the respiratory center in the medulla, and ventilation is stimulated. But just now I told you that as the ventilation gets stimulated because of the hypoxic situation there, CO2 will be washed out of the body. Carbon dioxide is washed out as ventilation has increased. And CO2 and H plus washed out means that will act via central chemoreceptor and the ventilation will be depressed. Remember, I mentioned just now that increased CO2 and therefore increased hydrogen in the vicinity of the central chemoreceptor will stimulate the ventilation by stimulating the respiratory center in the medulla, and decreased CO2 and H plus will depress the ventilation via the central chemoreceptor action. Now, that's the problem, that there is a hypoxic situation. It's going to stimulate the ventilation via peripheral chemoreceptors, but as the ventilation gets stimulated, CO2 is washed out of the body, CO2 and H plus decrease, H plus concentration decreases in the milieu of those neurons in the medulla, and therefore the ventilation gets depressed due to the action via central chemoreceptor. So, hypoxia driven ventilation and increase in ventilation, that effect got blunted because of the changes in the concentration of CO2 and H plus acting via central chemoreceptor. So, this is an important thing, and this is why the mountaineer may feel breathless and dyspneic. Oxygen is falling, it's stimulating the peripheral chemoreceptor, but just as the ventilation increases, CO2 and H plus washed off, and therefore ventilation gets depressed via action on the central chemoreceptor, decreased CO2 and H plus acting via central chemoreceptor. Now, a second response is a slightly delayed response. Now, what happens after say about 10 to 12 hours or so, there is a delayed response that is seen. What really happens is CO2 and H plus have been washed out of the body after initial stimulation of ventilation. H plus washed out means now it's a condition of respiratory alkalosis. So, how the body responds is by doing two things. One, these alkalis, mind you, I said it's alkalosis now, H plus has been washed out. So, the pH in the milieu of these central chemoreceptors, that has to return to near normal, and arterial pH, blood pH also has to return to near normal. So, two things happen at this stage. One is that there is a bicarbonate pump. I repeat, there is a bicarbonate pump. It pumps the bicarbonate out of the CSF. Remember, there was alkalosis. H plus was washed out, so there was alkalosis. So the bicarbonate, which is an alkali, is pumped out of the CSF. So bicarbonate sent out, and therefore that alkalosis will be neutralized. pH of the milieu around these neurons is moving towards normal once again. And the second, which occurs after 10 to 12 hours, is that kidneys begin to excrete the bicarbonate into the urine. So blood pH will also begin to return towards normal. Therefore, remember, ventilation had increased, it washed out CO2 and H plus, therefore there was respiratory alkalosis, but that alkalosis will get neutralized. Body is now slowly adjusting to after the initial reaction. Now the body is responding in its own favor, that the alkalis will be washed out of the CSF by the bicarbonate pump, and the kidneys also will start excreting out. So pH of the CSF will return to normal, and pH of the arterial blood will also return to normal. Therefore, these are the things that happen after a few hours spent at the certain heights. Apart from this, the other reactions, mainly the reaction was related to the respiratory system, because it was a hypoxic situation. And mind you, I repeat again, it's a hypoxic hypoxia. You know, there are 4 types, but we are concerned with hypoxic hypoxia. Cardiovascular reaction, of course, there will be increase in the heart rate and cardiac output, because as a reaction to hypoxia, increase in the cardiac output, so that oxygen delivery to the tissues could be maintained. Digestive tract, well, you know, since the pressure around the body is decreasing, and you know the simple principle of physics, PV is equal to constant, P into V is equal to constant. So if the pressure falls, the volume is going to increase for the gas. So what happens here is, there is a loss of appetite and expansion of gases in the intestine. So the person starts feeling a feeling of bloating, abdominal bloating, cramps and pain. What's acute mountain sickness? It develops after 8 to 12 hours of arrival at the heights. Symptoms such as headache, irritability, insomnia, nausea, vomiting and dyspnea. So these are the symptoms which one relates with acute mountain sickness. It develops 8 to 12 hours after arrival at a certain height, and impairment of the mental functions related to the hypoxia again. Now there are 2 very serious conditions that should be looked for. One is acute pulmonary edema and acute cerebral edema. So these are the 2 very serious complications of acute mountain sickness. Pulmonary edema is due to the fact that there is increased pulmonary vascular resistance. As I mentioned just now, some time back, hypoxia in the lungs leads to vasoconstriction. So pulmonary vessels are going to constrict. There is increase in the pulmonary vascular resistance, and therefore it may result in the acute pulmonary edema. On the other hand, acute cerebral edema, because of the cerebral vasodilation. I mentioned hypoxia leads to vasodilation everywhere in the body except for lungs. So in the case of cerebral vessels, there will be acute cerebral edema because of vasodilation of the cerebral vessels. In fact, many symptoms of the acute mountain sickness are due to this cerebral edema: headache, irritability, impairment of mental function and so on. Not edema, but because of dilation of the cerebral vessels, I must say. Right. So here is a table that if a person is breathing 20% oxygen, which is the case if you are not carrying oxygen cylinders, and you're just ascending into the mountains, just like that, what's going to happen? You are going to inspire 20% oxygen. 20% is the fraction present in the atmospheric air. So during ascent, the various symptoms of hypoxia, for instance, at 12,000 feet, there would be acute mountain sickness. So nausea, vomiting, irritability, headache, and so on. At 13,000 feet, there would be acute pulmonary edema. At about 14,700 feet, there would be acute cerebral edema. This, again, let me reiterate, this is when you are not carrying any oxygen cylinders, you are not allowing the body to acclimatize, you are not climbing slowly. So these are the problems that one might face. At 16,400 feet, there are flame hemorrhages in the retina. So cerebral vasodilation would be followed by the hemorrhages in the retina. There would be painless loss of vision. At 18,000 plus feet, there would be deterioration, further deterioration. There would be weight loss, anorexia, and general listlessness. At 20,000 feet, there could be a loss of consciousness. Now, if a person is breathing 100% oxygen at high altitude, suppose you are carrying oxygen cylinders. Look, when you are inspiring atmospheric air, you are getting 20% oxygen. I mean, there is 20% fraction which is oxygen in that air. But if you are carrying the oxygen cylinder, then you are inspiring 100% oxygen. So obviously it would be 5 times greater. So for a person breathing 100% oxygen at the heights, maximum height up to which the person can ascend, and yet there would be a normal alveolar PO2 is possible at around 34,000 feet. Remember, the barometric pressure at that height is barely about 187 mm of Hg. So the point is, at 760 mm of Hg, that's the barometric pressure. The oxygen pressure in this air is about 159 mm of Hg. Whereas at that height of 34,000 feet, the barometric pressure would be just about 187 mm of Hg. And imagine oxygen in that, oxygen pressure or partial pressure of oxygen would be 20% of just 187. So it would be a hypoxic situation. But since you are carrying 100% oxygen cylinders, you can deal with that low barometric pressure and the resultant hypoxia, hypoxic situation. Right. So at various heights, at 14,000 meters or more than 38,000 feet, consciousness will be lost in spite of inhaling 100% oxygen, because then still there would be so much of low oxygen being made available would be so less for the body that consciousness might be lost. And at 19,000 meters, now since feet will be too much to mention, it's mentioned in meters, 19,000 meters, the barometric pressure is just 47 mm of Hg. Now, this is a hypothetical situation, but it's an interesting situation. So let me just explain this. If the barometric pressure at that height, 19,000 meters, now I'm taking it as a meters for now, the pressure of the atmospheric air would be just 47 mm of Hg. You know what is likely to happen? The body fluids may boil spontaneously. Yes, the plasma water or body fluids may start boiling spontaneously. They may boil. Yes, 47 mm of Hg is the partial pressure of water vapor. At that pressure, the water is in the gaseous state. So water will have that boiling point at that pressure. So, of course, this is a completely hypothetical situation, because one cannot reach that height without its consequences. I mean, before that there would be sub-zero temperatures and so on and so forth. So person will not be able to survive and reach that height. So this is just a hypothetical situation. And then chronic mountain sickness, also called as Monge's disease, there would be extreme polycythemia, because as a result of a chronic exposure to hypoxia, the kidneys begin to release erythropoietin. There would be increased erythropoiesis, and therefore RBC count increases tremendously. There would be extreme polycythemia. And then there would be malaise, fatigue. In fact, because there is increased pulmonary vascular resistance, increased pulmonary artery and capillary pressure, it might result in right ventricular hypertrophy, because right ventricle has to pump the blood through the pulmonary circuit, and in fact even it might lead to right ventricular failure, right heart failure, right-sided failure. So these are the manifestations of chronic mountain sickness or Monge's disease. So having said all this about the hypoxic situation and how the body responds immediately, what are the consequences, now let us see the acclimatization to this hypoxic condition, acclimatization to high altitude and the hypoxic environment. Now, let us talk about the chemoreceptors. Two things which are going to happen. One, there is increased sensitivity of the peripheral chemoreceptor. Yes, increased sensitivity of the peripheral chemoreceptor means it is going to normally respond to hypoxia. We are aware of that. Now, it will respond even more to the hypoxia in the arterial blood. So, if it was sending X number of impulses sensing hypoxia, now when the person gets acclimatized, well, that happens within 2 to 3 days at a certain height. So after 2 to 3 days, we are looking at acclimatization to the high altitude and hypoxic environment. So now with acclimatization, the peripheral chemoreceptor will generate more number of impulses. It has become more sensitive because anyways the situation is going to remain hypoxic. So it's going to generate more number of impulses and it's going to be more sensitive to hypoxia. And second, most important aspect is there is decreased sensitivity of the central chemoreceptor in the medulla. Remember, we mentioned central chemoreceptor is sensitive to CO2, arterial CO2, and therefore the H plus which are formed because of the CO2. So there is decreased sensitivity. Why? How is it beneficial? It's quite easy to understand. Look, we said in the beginning that hypoxia stimulates the peripheral chemoreceptor and that stimulates the ventilation. But as the ventilation is stimulated, CO2 and H plus is washed out of the body and therefore decreased CO2 and H plus depresses the ventilation via the action on the central chemoreceptor. So it blunts the effect of hypoxia on peripheral chemoreceptor and stimulation of ventilation gets blunted. So now after acclimatization, what's happening is the sensitivity of central chemoreceptor is decreased. Decreased sensitivity to what? To the changes in CO2 and H plus. And why does that happen? Partly we have answered that question, because initially when ventilation was stimulated, CO2 and H plus was washed out and therefore there was respiratory alkalosis. But then as it settles down, as the acclimatization sets in, the bicarbonate ions will be pumped out of the CSF and bicarbonate will be excreted by the kidneys, and therefore pH returns normal, towards normal, and the neurons are losing their sensitivity slowly to the changes in CO2 and H+. So, even if there is respiratory alkalosis, let's say, it will not affect the ventilation via central chemoreceptor. Even if CO2 and H plus is washed out of the body, it will not depress the ventilation via the action on central chemoreceptor, because central chemoreceptor sensitivity itself has been decreased during the process of acclimatization. So, these are the two important changes of acclimatization to high altitude which happen within 2 to 3 days at a certain height. Apart from these, the other changes, of course, we have seen that there is increase in the cardiac output, and which will maintain the blood flow to the tissues and maintain the oxygen supply to the tissues. Kidneys, they will increase the production of erythropoietin. Erythropoietin will stimulate the erythropoiesis, so RBC count will also increase. That will offset the effects of hypoxia. The more RBCs, that means more oxygen possible to be delivered to the tissues. That's another important feature of acclimatization to high altitude. And another important feature about 2,3-diphosphoglycerate. So, let me just explain this in detail. When the person is ascending into the mountains, when the person is facing the hypoxic situation, the oxygen dissociation curve is shifted to the left. Remember, the oxygen dissociation curve is the relationship between percent saturation of hemoglobin with oxygen and the PO2. So, PO2 100 mm of Hg, 60 mm of Hg, 30 mm of Hg. What you see here is the curve appears like this. From 100 to 60, there is hardly any decrease in the percent saturation. The curve is flat. This part is beneficial during acclimatization. This part is good for acclimatization, the flat portion of the O2 dissociation curve. Because as we are ascending into the mountains, the PO2 in the alveolar air and PO2 in the arterial blood is falling, as we have mentioned, from 100 to 90 to 80 to 70. Look what is happening. The curve is flat. Flat portion means the percent saturation remains the same. It's not falling, it's not coming down. So it means hemoglobin takes up the oxygen and holds the oxygen. So percent saturation remains full. Hemoglobin completely saturated with oxygen, even though PO2 is falling due to the hypoxia. Now this part is beneficial. But if the PO2 in the alveolar air goes below 60, then the percent saturation, you can see it drops. That means hemoglobin is going to lose the oxygen readily in the range below 60. So remember, alveolar PO2, which is normally around 100, if it goes below 60 due to the hypoxic situation, there will be slightly a problematic situation, because hemoglobin is known to deliver the oxygen very readily when PO2 is going below 60. Between 60 and 30, you can see the curve is steeply coming down. That means percent saturation of hemoglobin is falling steeply for a very small fall in the PO2. So hemoglobin gives up the oxygen in this range. Well, that PO2 generally is there in the tissues normally, so it's beneficial under normal circumstances. In hypoxic situation, it may not be as beneficial. Now, respiratory alkalosis, it's going to shift the curve to leftward and upward. Remember we said hypoxia stimulates ventilation. When ventilation stimulated, CO2 and H plus is washed out of the body. H plus gone, that means it's respiratory alkalosis. Alkalosis is known to shift the curve to the left. Remember, increase H plus, acidosis will shift the curve to the right. Decrease H plus means alkalosis will shift the curve to the left. So, during ascent into the mountains, alkalosis and the curve will be shifted to the left, but then as a process of acclimatization, now this is important part, note this, as a part of acclimatization, the glucose inside the red cells, which would otherwise undergo glycolysis, it is shunted and the shunt is called as Rappaport-Lubering shunt. So after glyceraldehyde 3-phosphate, there would be 1,3-diphosphoglycerate and formation of 2,3-diphosphoglycerate. Once this starts forming, then the curve is again shifted to the rightward and downward. So initially the curve shifted to the left, that was because of alkalosis, and as the process of acclimatization sets in. Now let me just also explain. More formation of 2,3-diphosphoglycerate. Once this is formed inside the red cells, it binds with hemoglobin and displaces oxygen from hemoglobin. Simple displacement reaction. So more oxygen can be delivered into the tissues. Remember, shift to the leftward and upward means hemoglobin holds the oxygen, does not deliver the oxygen readily. Whereas shift to the rightward and downward means hemoglobin will deliver the oxygen easily, more readily. So that's what's going to happen by increased formation of 2,3-diphosphoglycerate or bisphosphoglycerate, 2,3-BPG. That's another important feature of acclimatization. So, last few points. For the acclimatization, what is the golden rule? The golden rule is climb high but sleep low. So, in a day, you should climb and sleep at 1,000 feet above. I mean, you should have traveled 1,000 feet in a day. For instance, what I'm trying to say actually is, suppose you have gone 5,000 feet in a day, then come down by 4,000. Yeah, suppose from 10,000 feet you went to 15,000. Then come down and stay at night at 11,000 feet. So in a day's time, you should have climbed at by 1,000 feet for the sake of acclimatization. So climb high but sleep low. That's the golden rule for acclimatization. Allow the body to prepare to face the hypoxic situations and the changes that will occur subsequently during the acclimatization. The drug acetazolamide, it's a carbonic anhydrase inhibitor. It's a diuretic and it favors the excretion of bicarbonate. We have seen this just now, that the kidneys excrete bicarbonate and compensates for that respiratory alkalosis. So, carbonic anhydrase enzyme, we discussed the reaction. CO2 combines with water to form H2CO3, and this reaction, it's a reversible reaction, and this reaction is catalyzed by carbonic anhydrase. So, acetazolamide is a carbonic anhydrase inhibitor, it's a diuretic, and it helps in the process of acclimatization. It helps in the conditions of acute mountain sickness by early excretion of bicarbonate and inhibition of carbonic anhydrase enzyme. So, it helps to counter the effects of hyperventilation in a way. So, these are the problems of low barometric pressure, the resultant hypoxia, and how the body acclimatizes to the hypoxic situations. In fact, the people residing in the mountains, generations and generations are staying in the mountains. You will see that there are certain changes which we call adaptation, such as their chest size increases, almost the barrel shaped chest, because their total lung capacity increases. With a chronically heavy breathing or hyperventilation, their total lung capacity, their tidal volume is going to be higher. Cardiac output is going to be higher. Normally about 5 liters per minute, they will have 7 to 8 liters per minute, in fact, quite possible. So, that's because hypertrophy of the ventricles happens due to the chronic situation or generation to generation facing hypoxic environment, and they will have RBC count up to 7 to 8 millions per cubic millimeter. So, these are the things that are seen in the populations that stay in the mountains from generation to generation. So, that was a topic of or problems related to the low barometric pressure and acclimatization to that.